right. Well, welcome everyone to another weekly conference. And just a reminder, the next 2 weeks we're off because of vacation, so there will be no conference. But today we're going to be talking about ethical considerations at end of life. I'm Dr. Trexler from Kalamazoo. Today we'll talk about some of the causes and nature of ethical conflicts at end of life, and review ethical principles to specific cases, and addressing issues of informed consent, decisions, and limits, including the principles of substituted judgment or surrogate decision-making and best interest standard, as well as discussing DNR, withdrawal of life-sustaining treatments, and identifying strategies for dealing with conflicts, particularly when there are requests for non-beneficial or futile treatments. I'd like to start with a case. This is probably one of the most difficult cases I've ever dealt with in my entire career. Not so much because of the patient, but because of the family, as is often the case with ethical issues. This is a 64-year-old man who had an ERCP and developed pancreatitis, septic shock, renal failure, respiratory failure, and heart failure. 3 weeks into his hospital stay, he wasn't improving, and the son asked a lot of questions and literally demanded hours of the ICU team's time. He also contested blood transfusions, refusing to allow dialysis initially, delaying initiation of these by several days. And finally, palliative care was consulted for goals of care. The son met us at the door and initially refused to let us in. But with further education about the supportive nature of palliative care, he did allow support, but didn't want any symptom management or anything like that. I think he must have thought that we were the death squad or hospice, or ready to just focus on end of life and euthanasia or something like that. I don't know. But he definitely was suspicious of us and was reluctant to let us even be involved in the case. Of course, the patient was full code. 2 days later, the son fired palliative care because there was a misunderstanding. He thought that we had ordered the fentanyl that the patient had received, and he had specifically said no opioids. And he also fired several ICU residents, nurses, and attendings. The staff was very frustrated. They felt very conflicted, angry at the son because he was being so difficult in their eyes. So consult palliative care, but we're not ready for that yet. So we're not the euthanasia service or the death squad. Important issues to consider whenever you're facing a difficult patient or family situation. It's helpful to break it down into several elements. First, what is the ethical question? And oftentimes this addresses issues of what feels right or what feels wrong, what feels like it's doing more harm than good for the patient. What is the type of the conflict? Who are the involved parties or the stakeholders? What do you think is causing the conflict? And what are the relevant values and ethical principles that we can use in helping to move forward? And most hospitals nowadays have ethics consult services, and there are many reasons to consult them. A lot of times, especially the nursing staff, have moral distress, and the treating physicians and APPs also. Something just doesn't feel right. I've heard nurses say, I feel like I'm torturing him. Or there may be patient rights issues which are in jeopardy, or a patient who is being very non-compliant for whatever reason. There may be conflicts about treatments or goals, decisional capacity issues, and surrogate decision-making or lack thereof. Usually when there's a lack of surrogate decision-making, then some of these ethical issues become more relevant. Non-beneficial treatment, or what seems like futile treatment, and then end-of-life decisions when not everyone is in agreement. There are several types of conflicts. Often they're related to medical decision-making or surrogate decision-making or decisions. Goals of care, which is where palliative care lives and breathes. 75% of our consults are for goals of care. And then artificial life supports, whether to avoid them, continue them, or withdraw them. And then the parties that are involved, the stakeholders. Of course, the patients. Then you have the family or the surrogate decision maker. You have staff, which could include attending, consultants, nurses. There are many causes too. Usually it revolves around unmet expectations. Often the patient is worsening medically or has experienced complications of procedures. There may be poor communication with the family or the patient. There may actually be poor care. There may be the perception of medical negligence or error. Well, he was fine last week. What did you do to him? Families often are in the denial or anger stages of grieving, and so that often drives a lot of the conflict initially because they're not ready to lose their loved one, and that's understandable. They may have a belief in miracles against all odds that may cause them to want to do things that the medical team does not feel are medically appropriate. And then the patient's wishes for quote unquote everything to be done or not, and the patient's mental state or mood. Many times, if you see a patient who's extremely depressed, maybe because they're in terrible pain, they would rather die than live like this. But then once their pain is controlled or once their depression improves, they want to keep going. They want to keep doing the medical treatments. I'm sure you're all familiar with the core or classical ethical principles of autonomy, beneficence, non-maleficence, and justice. But for the sake of completeness, no ethical talk would be complete without mentioning these. But autonomy is what drives a lot of medical decisions in our society. Patient Self-Determination Act in the early 90s, the right to make decisions or refuse treatment, advanced directives have been encouraged through this, or living wills. Beneficence, this supports the best interest of the patient. What would give them the best quality of life? What would be most medically appropriate to help them improve or get better? Non-maleficence, first do no harm. We want the benefits to outweigh the burdens of any treatment, including decisions about surgeries or transfusions or other things like even intubation or dialysis. And then justice. There needs to be objectivity, a uniform standard of care, fair allocation of resources, and good stewardship. So treating everyone, making sure that everybody is treated with equity. Other moral and ethical principles include dignity or respect for persons, which is related to autonomy, but it's a little bit different, a little bit deeper. Proactive, open, and honest communication, kindness and compassion, and proportional benefits versus burdens. In other words, maximizing the benefits of treatment and minimizing the burdens, with the ultimate goal of relieving suffering or trying to prevent suffering. Another case, this gentleman has had COVID. He refused a ventilator with worsening oxygenation, was on maximal high flow oxygen for 2 weeks. His family disagrees and insists that he be intubated if he worsens. Or a 66-year-old woman with vascular disease, heart failure, heart disease, renal failure on dialysis says she does not want to continue dialysis anymore. Her husband cannot bear to lose her and insists that she continue. She has hypotension and worsened pain during dialysis. The dialysis nurse feels like it's torture, and the patient agrees. So in both of these instances, we have a patient who wishes to limit or withdraw a medical treatment and a family who disagrees. So what is the ethical question? Well, do we continue or discontinue the artificial life-sustaining treatment? That's the basic question is can patients be allowed to stop medical treatments once they're started? The answer is yes. If you can start it, then you can stop it. If you can choose to do it, then you can choose to withhold it or discontinue it. What is the nature and cause? So often it's conflicting goals of care. The patient wants comfort and quality of life. The family wants their loved one around longer because they're not ready emotionally to lose them. Who are the involved parties? Well, the patient, if assuming they're decisional, the family, staff, and then the relevant values and ethical principles. So obviously autonomy is going to be a big one. Can the patient, should we respect the patient's autonomous desire to stop dialysis, even if it conflicts with the family's wishes? I think most people would agree, yes, the patient should be able to make that decision. But the timing of that decision is where palliative care is often able to come in and help get everyone on the same page. And it's often a process, usually revolving around goals of care discussions. Also with these cases, beneficence, and beneficence and non-maleficence. If the treatment or dialysis or other medical procedure is more burden than benefit to the patient, that could be a reason why they would not want to continue it. They don't feel like it's achieving their goals of dignity or quality of life or whatever. So establishing goals of care. I know we have other lectures on this during the year, but just for a brief summary, one of the ways I approach it is I don't just come right in and say, what are your goals of care? I try to get to know the patient first, because that really helps build the rapport and help us know them as a person, to better understand where they're coming from. And that's key. When you're dealing with conflict, always ask, why is there conflict? What is the underlying either cultural, religious, personal, what's going on in that patient's life or the life of that family or their past experience that is driving this decision. So that you can ask about, what was their lifestyle like before this, before they got sick, and then what's their health been like? And by asking questions at each step of the way, that invites dialogue, rather than if you make a statement, they could argue with that or they could disagree, and then you have a conflict. Whereas if you ask questions, tell me about what your life's been like, or what you like to be able to do, and have you been able to do that recently? How long has it been since you've been able to fish or hunt or do whatever brings satisfaction and meaning in your life? What health trends have you seen? How have things been going related to your health? And what if the doctor's told you about your conditions or and then trying to use simple language rather than medical terms. So what if the doctor's told you about your medical conditions and how things are going here in the hospital? What have the doctors said about what to expect in the future? And if you became really sick, who would make decisions for you? And then what's important to you? What do you value most? What are you afraid of or worried about? What are you anxious about? What are you hoping to avoid? Or Atul Gawande, in his book Being Mortal, asks the question, what is it that you would give up for the opportunity to live longer? What are the trade-offs? And then once you've identified what's most important to them and what their goals are and what they're hoping for, then you can talk about their preferences about end-of-life care. So when their health gets worse, have they thought about whether or not they would want to be on artificial life support machines? And then if so, is that something they would only want temporarily for a time-limited trial, or would they want it long-term? And then the next steps, where do we go from here? So this is just a helpful framework that I've used for years, and it seems to work pretty well. Can be done in as little as 5 minutes or as long as an hour, depending on the issues. Another model, which I'm sure you're familiar with, is this house model, where you build a relationship, you hear their story, then you present the medical information, and then you make a balanced medical recommendation and arrive at collaborative decisions. Another case. This is a homeless man found down, lethargic, dehydrated, with a glucose of 400. He was admitted to the ICU, given IV fluids, insulin, electrolytes. He inconsistently nods yes and no to questions, but seems to resist nursing care and mainly just wants to be left alone. So here we have basically an unrepresented patient. We don't know if there's any family. We don't think that he has decisional capacity because he's inconsistently nodding yes and no. So we don't know what he really means when he nods yes or no. Now, decisional capacity, and we had a lecture earlier on this, which was excellent, but just by way of review, capacity is different from competence, which is legal determination. Capacity refers to the ability to make specific treatment decisions. And it requires someone to be informed, to be able to understand the medical information. It has to be voluntary rather than coerced. It has to be a reasoned decision, not just on a whim. Oh yes, I'll do that. No, I won't. Back and forth. And then it has to be a choice that is able to be communicated. So if somebody can't understand the information, or if it's a forced decision, you want to do this, don't you? And yeah. And the patient has to be able to communicate some kind of a decision. Otherwise, you can't truly say they have decisional capacity. Unfortunately, in the hospital, especially the ICU, people are on a lot of medications, sedatives, they're really sick, and so that can affect their mentation. They may have delirium or even severe depression. So informed consent and medical decision-making, just to touch on this by way of review, informed consent for elective procedures or treatments, you have to be able to understand the risks, benefits on alternatives and the burdens. It has to be discussed prior to the procedure, and the patient verbalizes a decision to proceed. For emergency procedures, you may proceed without signed consent in order to save life or limb. And this is a professional recommendation without coercion. For medical decision-making, there's the patient. If the patient can't make a decision, then the family or surrogate decision maker. And then if there's nobody around and then the physicians just have to say, well, you know, what should we do? What would be the best medical treatment that would be most appropriate in this situation? So we call this shared decision-making, where there's dialogue between the provider and the patient or family. But who ultimately decides? What if a patient or family decision goes against the doctor's wishes or the standard of care guidelines? What do we do then? What do you guys think? So the family or the patient is demanding something that you know is not going to work or is just plain not good medicine. Do you have to do it? Feel free to speak up if you want, but okay. So no, you don't have to do it if it's not good medicine. You shouldn't do it, in fact. So if the patient is not decisional, there are two ethical principles that come into play. Number one is substituted judgment. Number two is best interest standard. So substituted judgment, this is where we're talking about surrogate decision makers. So, and if there's any patient wishes that have been expressed. So either written, like an advance directive or a living will, or verbal statements, or implied. And this is the lowest level of evidence. It's more like inference. So life values, lifestyle, how they live their lives. This is somebody who tried to avoid doctors and hospitals, and just really wanted to just eat whatever they wanted, do whatever they wanted, didn't want to be shackled down by medications or expectations from the physicians. What are their prior patterns or behaviors? And then surrogate decision makers. Technically, in the state of Michigan, there's no absolute hierarchy of next of kin. But in some states, it's the spouse followed by the adult children, followed by parents, followed by siblings, followed by others or other concerned parties. But definitely a legal guardian carries more weight than even a DPOA. And then surrogate decision making requires several things. You have to have an adult who actually has decisional capacity, and they have to be capable and willing to make medical decisions. We've had people that are able to do it, but they just refuse to make a decision, or they won't return phone calls, and that's a problem. So really, they're not acting in the best way to be a good decision maker if they're not available and if they're not cooperating. And they also have to be respecting the patient's wishes. So if the surrogate decision maker or the DPOA says, maybe they even say, well, the patient's still decisional. Well, I'm the DPOA. You have to do what I say. I don't care what she says. You have to do what I say. No, you don't. If the patient's decisional, you go by that. If they're not decisional, the surrogate decision maker may request treatments, but if those go against the patient wishes, you're supposed to honor what the patient has previously expressed as their wishes. And I think they usually throw a question on the board exam related to this issue. So technically, you're supposed to do what the patient would have wanted done, even if the DPOA disagrees. Standards for substituted judgment are standards for surrogate decision-making. Substituted judgment, what would the patient do or say? And the best interest standard, what's in the patient's best interest. If the surrogate decision-maker is failing to meet this criteria, they may actually be removed. It's best done with an ethics consult to have their backing, but we have done this in the past. In fact, that's what we ended up doing in the case of the first patient that I presented this morning, because fortunately, he had a brother who was available and willing to talk and was much more cooperative. And so the ethicists actually recommended removing the first son as the surrogate decision maker in place of the second one. All right, so the best interest standard, that is a legal standard of caregiving for incompetent patients. Now, they should have used incapacitated, but anyway, although in this case, they're saying defined by the courts. So I guess incompetent would be the correct word. In terms of what a, quote, reasonable person would decide in the same situation. A consideration of best interest generally attempts to weigh the burdens and benefits of treatment to the patient in his present condition, with no clear preferences of the patient can be determined. And there are three features of the surrogate decision maker choices. They can use the best available information to assess the patient's immediate and long-term interests, prioritizing the option that maximizes benefits, minimizes burdens, consider treatment versus no treatment, effect on quality of life, and the balance between beneficence and non-maleficence. It has to meet the minimum threshold of acceptable care and compatible with moral and legal duties to incapacitated individuals. So in other words, if, say, there is no surrogate decision maker and the physicians are trying to act in the best interest of the patient, then they have to factor in benefits versus burdens, effect on quality of life, minimum threshold of acceptable care, and what duties they have to the individual. So quality of life, certain treatments that are not excessively burdensome for comprehending patients, in other words, you and me, can be excessively burdensome for patients with dementia, where complications created by the person's lack of understanding often change the judgment of how to best serve his well-being. The goal of ethical caregiving in a clinical setting is not to extend the length of life or postpone the end of a patient's life as long as medically possible, but always to benefit the life that the patient still has. It's all about quality of life. The goal is not to increase the length of days, but to improve the quality of days. And I can't emphasize that enough. Oftentimes there are conflicts when patients' families want them around as long as possible, but their quality of life is going to suffer. And so again, bringing this back to what really matters in the end to patients is how they live their life, not if or when, but how they live. So the best interest standard summary, the goals are optimizing comfort, improving symptoms and quality of life while minimizing the risks, harms, and burdens of treatment. I'd like to touch on dealing with conflict and unrealistic expectations, because this is very common in our field, especially in the ICU setting or at end of life. This is a 72-year-old woman admitted to the ICU after urgent cardiac catheterization for MI, cardiac arrest. She's on a balloon pump, a ventilator, vasopressors. The daughter arrived and said that she would never want to live on life supports and requested withdrawal. Of course, the cardiologist objected. In this case, he said, I am ethics for my patients. And it was clearly too early to prognosticate, and the patient needed more time. So he reversed her DNR, making her full code again. 2 days later, as the patient had developed renal failure and was not improving neurologically, the daughter again requested DNR and ventilator withdrawal comfort care, which was honored after multiple discussions, including with cardiology, and the patient died comfortably. So what's the best way to handle conflict? Listen respectfully, determine the source, clarify misconceptions, focus on the patient's well-being, negotiate disagreements like a time-limited trial, or all of the above. And by the way, I can't see the chat, so actually, okay, I just, now I'm able to see it. Okay, F, yes, all the above. So dealing with conflict, it's usually the best principle initially is to try to listen and just seek to understand where they're coming from. What's the background, beliefs, and values of the family? What are they hoping for? What are they afraid of? What stage of grieving are they in? Oftentimes it's denial or anger. Always communicate with respect. Ask about what they've been told, or what their impression of things or their understanding is, and try to clarify misunderstandings once you've listened to them or listened to them vent. Above all, avoid harming the patient. Don't offer medically inappropriate treatment. So if the medical team does not believe that doing a procedure would actually benefit the patient, then they should not even offer it. They may explain why the person's not a candidate for that. But if you offer a treatment, people will interpret that as, oh, this is a viable option. Okay. And some people will take every treatment that is offered to them because they're not ready to let go. And then the team gets mad because they feel like, oh, we shouldn't be doing this. We shouldn't be doing a trach on this person who's, clearly dying. And so then, it creates more conflict among the team. But so that's why it's helpful. If it's truly going to be non-beneficial, do not offer the treatment. If it could potentially be beneficial, you may offer it. And the idea of a time-limited trial is very helpful with specific goals identified. In other words, okay, let's try it. And then let's assess periodically, how are things going? Is the person getting better? Are they staying the same? Or are they getting worse? An ICU attending told me last year, he said, in the ICU, if somebody is not getting better, then they're actually getting worse. And that's because every day that they're on a ventilator or life supports, their body is getting weaker and more dependent on those things. And then, of course, communicate regularly with family. So let's talk about some specific strategies for end of life. Here's a case of a man with advanced dementia, massive intracranial hemorrhage, who's full code. He's dependent on ventilator, dialysis, and vasopressors, and the family on admission said, do everything. Code status was discussed, including risk benefits versus burdens. And in this case, we used the GOFAR score for the odds of CPR success with intact neurologic function. And the family was unsure. They wanted more time and couldn't bring themselves to say not to do CPR. Here's another case where an alcoholic with liver disease, history of meth use, was admitted to the ICU with respiratory failure, COVID, pneumonia, ARDS, shock, both cardiogenic and septic. He's on a ventilator, 100% oxygen requirements, pressors, sedatives to prevent alcohol withdrawal. He developed renal failure, severe acidosis, required CRRT dialysis, and the family said, do everything. He has no DPOA. His next of kin is a minor. His ex-wife is uninvolved. Sister refuses to make decisions or return calls. And the niece, who's over 18, also refused to make decisions. So let's talk about some different levels of consent and medical recommendations. So informed consent, this is where the family or the surrogate stated, don't do CPR if the heart stops. These are just examples. Informed assent would be the family couldn't bring themselves to say no to CPR, but they agreed with the physician recommendations against CPR in this situation. And then informed non-dissent. This may be a new concept for some of you. This is where the family's informed and they voiced no objections to not doing CPR. In other words, you could say, based on all the life supports that your loved one is on, if or when the heart stops, despite everything we're doing, we are not going to do CPR because it's not going to work. And we don't believe that it would help. But we recommend allowing natural, peaceful death. And the family doesn't, either they don't say anything or they don't voice any objections. And technically, if you have two providers both agreeing that CPR would be medically non-beneficial and the family voices no objections, then you can change code status to DNR without the family specifically verbalizing, yes, they can. So this is called informed non-dissent. Let's talk about non-beneficial treatment. What formerly was called futility. There's a lot of debate in the literature, but generally people don't like this term nowadays because the family might perceive something as having benefit. Well, he's alive, isn't he? Whereas the medical team may say, well, yeah, he's alive, but he's slowly dying and it might take weeks, and we know where this is going, so we don't think that this is going to really help him get better. So that's why they use the term non-beneficial, meaning it's basically unacceptable likelihood of achieving an effect that the patient has the capacity to appreciate as a benefit. It may involve excessive effort or finances or excessive medical intervention with little prospect of altering the patient's ultimate clinical outcome. Factors involved: considering the patient goals, the physician clinical judgment, especially related to prognostication, medical evidence and clinical guidelines, as well as other factors like financial, legal, sometimes even the media. When they get involved, they have a way of stirring things up. So non-beneficial or medically inappropriate treatment, there are several criteria, and you need one or more. Failure to achieve medical and physiologic goals, disproportionate burdens compared with insignificant benefits, or prolongation of the dying process. In other words, this is a terminal illness. Somebody has end-stage heart, lung, brain, kidney, whatever disease, and these artificial measures are just prolonging this. They're not really helping them get better. Physicians are not obligated to offer or provide or continue non-beneficial treatment. And this is determined by two physicians with input from ethics. Most hospitals that have non-beneficial treatment policies usually specify getting an ethics consult as well. There's an obligation to inform the family of non-beneficial treatments, give them the option of transferring care elsewhere if they disagree. And usually there's a time frame associated with that, anywhere as short as 5 days, as long as 10 days, depending on the institution. Also, in terms of changing code status to DNR, there are several reasons for withholding CPR from an incapacitated patient. Just because they're incapacitated doesn't mean you automatically have to do CPR or have them as a full code. So number one, strong evidence the patient would not want CPR. This, of course, would be the gold standard if you have something written or something stated. But also, if CPR would either fail to benefit or would likely harm the patient, in other words, the risks or burdens are out of proportion to the benefits, treatment would prolong the irreversible dying process, or there's no physiologic rationale or benefit from CPR. For example, if somebody is on 3 vasopressors and their heart stops, what do you think the likelihood is that CPR is actually going to bring them back and help them survive if they were having trouble surviving before that? And also another status here, or another consideration, is the well-being of the whole person and proportional benefit. So I've quoted here some ethical and religious directives that address these issues. And there is no obligation to provide medically ineffective treatments which do not respect human dignity of the person. Okay, going back to our case of where the family wanted everything and they weren't ready to let go, and the patient was on multiple forms of life support, basically ventilator, pressors, dialysis. There were many family meetings to discuss goals, during which the daughter, remember, she's 16, so she's a minor, but she actually was the most reasonable of the bunch. She had agreed with the medical recommendation for DNR by informed assent as well as informed non-dissent by week 1, but wanted more time. So we recommended a time-limited trial with specific goals or signs to help the family make the decision for continuing versus discontinuing life supports. And we also got ethics involved. After 3 weeks of multiple life supports, his acidosis was worsening and he remained unable to wean off the ventilator. He also showed that he was encephalopathic, basically comatose, despite no sedatives. So let's talk about the issue of withholding or withdrawing artificial life supports. This is permissible as an ethical, moral, and legal option. I refer you back to the landmark cases from decades ago, the Quinlan case and the Cruzan case, which established the right that once you start a treatment, you are not obligated to continue it, especially if the burdens outweigh the benefits. and removal of unwanted or burdensome artificial devices to allow natural death from the underlying illness or diseases is not murder, suicide, or euthanasia. To families, it may feel like they're killing their loved one. That is not the case. So when somebody says, I feel like I'm killing her, or I feel like I'm killing him, that's an emotional statement that begs to have an empathetic response. So responding with, this must be very hard. Tell me more about what you're thinking and feeling, and get them to kind of open up a little bit. And then gently educate them about how, and even using the term, removing the burdensome or unwanted artificial machines to allow natural death from the underlying illness or disease, helps put it in perspective and helps them realize that they're not the ones that are killing their loved one, because that's more like an active thing. Whereas the patient is already dying, the machines are merely prolonging the dying process. And so by removing the machines, it allows natural death from the underlying disease. That's important. Whether you're talking about deactivating a defibrillator, which isn't going to make someone die tomorrow, or whether it's withdrawal from artificial life supports, dialysis, ventilators, etc. So very important to help educate and respond to the family's emotional needs, and make sure that they're comfortable with this. The Catholic ethical and religious directives support withdrawal of life-sustaining treatment if the burdens are disproportionate to the benefits, if the patient would not have wanted the artificial treatments, if the medical treatments are no longer effective. In other words, they've become non-beneficial and actually harm the dignity of the person. There is controversy when there's disagreement among medical staff about the appropriateness of withdrawing the life-sustaining treatment, or when the family disagrees. So there may be conflicting values, judgments, opinions, and goals. I've noticed, at least among the medical staff, if someone is very young, it's a lot harder to opt for vent withdrawal and comfort care. Or if they have something that's potentially treatable but would require months and months in the hospital, and the patient says, I'm not doing that. I don't want to live like that. Or whether it's somebody who's on BiPAP, which that's keeping them alive, but after a while, the patient says, I've had enough. I don't want this anymore. It gets very hard in situations like that. But basically understanding that patients do have a right, or families have a right on behalf of their loved one to withdraw or refuse treatment if it's no longer beneficial to them. So some examples: CPR or not, ventilators, BiPAP, high flow oxygen, vasopressors, balloon pumps, temporary pacemakers, dialysis, artificial nutrition and hydration even. So here's some strategies. Obviously, the earlier you can communicate about goals of care, the better. And clear, honest communication about the patient's condition, about the prognosis, listening and respecting the patient and the family, and building that rapport early on. It's very helpful. Understanding the perspectives and the background. Where are they coming from? What's driving their decisions or their statements? What are the underlying emotions? And responding with empathy. Recognizing the underlying psychosocial and spiritual as well as cultural factors which may drive some of their decisions. This time of year, in fact, just yesterday, I was meeting with a patient who has said he had just, well, he was struggling. He didn't want to go on dialysis. And then he finally agreed. I think his family, I think, would have gone either way, but he finally agreed to try it. So yesterday he got his third dialysis treatment, and he basically said, how many times a week am I going to have to do this? And this is going to be for the rest of my life. I don't think I want to do this anymore. So his family was going to be coming in last night. So I'll find out today what they decided. But again, this is a situation where Christmas is coming, and he has 3 granddaughters that want him around for Christmas. So this could go either way. He might say, okay, well, I'll do dialysis through Christmas and then maybe stop after that. Or he might say, no, I don't care. Or I do care, but I don't want to continue dialysis, and I just want to be home and comfortable. And so we'll see what happens in a situation like that. But being willing to honor the patient's wishes, even if it may seem uncomfortable for some of the parties involved. Explore the benefits versus burdens related to quality of life. And most patients do not want to be a burden on the family, and they don't want the treatment to be a burden on them in terms of their quality of life. Above all, align treatments with patient goals and values, negotiate a time-limited trial with specific goals, especially if there's uncertainty about how things might go, and then follow up family meetings. The goals of care is a process, not an event. It's a series of discussions over time. Getting back to our ICU case, we had a final meeting with the daughter by phone and then in person. We again explained the clinical situation, noting the signs of patients slowly dying despite aggressive life supports. In other words, he was getting worse, not better. Agreement by both the ICU attending and the nephrologist to simultaneously stop the dialysis and the vasopressors, and the daughter voiced assent and no disagreement with stopping these, and he died shortly afterwards while still on the ventilator. Ethics had been consulted, and they agreed with the decision, and they agreed that this was medically inappropriate treatment because it was not helping him get better. So basically, it satisfied the criteria. Patient was, for the purposes of medical decision-making, unrepresented. So it's up to the physicians to make decisions according to the patient's best interests. But when these decisions are made, it is equally important that multiple physicians independently agree that treatments alleged to be medically inappropriate satisfy one of the above criteria, which occurred in this case. So in summary, I hope that you are better prepared to understand some of the causes and the nature of ethical conflicts at end of life. Review and apply ethical principles to cases, specifically addressing informed consent, decisions, limits, substitutive judgment, or surrogate decision-making, and best interest standard, approach to DNR and withdrawal of life-sustaining treatments, and strategies for dealing with conflicts, particularly related to requests for non-beneficial or futile treatment. And I hope you guys have a very Merry Christmas. Are there any questions or comments? I'll stop sharing my slides.
Just thank you so much for this overview. I thought a lot of the principles are things that can come up on boards and can be some of those tricky questions, like what's that right answer? So I appreciate the ethical sides and the terminology that we all need to be familiar with along those lines. And these are always tough processes, I think, even in our hospital, even though we know two physicians can sign and say, this is what we're going to do, that is often some organizations, I think ours is one, is pretty risk averse, and it takes a lot to get to that point. And so everyone will find wherever they work, there may be a lot more steps and discussions to get to that point at some places than others. But yeah, I think your recommendation involved the ethics team and, care conferences with just the medical team members to talk through these complex situations is really helpful. So we're not in the room and all having different opinions in front of the family, like talking ahead of time is helpful.
Yeah, thank you. One of the frustrations that one of the ICU attendings expressed to me recently was that he feels like the surgeons can say, oh, the surgical risk is too high, we're not going to operate. But yet when it comes to intubation, he feels like his hands are tied. Somebody with end-stage lung disease, end-stage dementia, develops respiratory failure, clearly they're actively dying, they're at end of life. And he feels like we, quote unquote, shouldn't be doing this. We shouldn't be putting them on a ventilator. This is futile. So the problem is that the ventilator is an immediate stopgap, life-saving well, maybe life-saving for now measure, ultimately it slows
Yeah.
down the process of dying, and it gives
Mhm.
more time for family to show up or for the patient to be stabilized. When, because making a snap decision in a crisis is a lot harder than to be able to sit down when there's a little more time and say, well, okay, let's talk about how this could benefit, how it could burden or harm, and what the effect on the quality of life would be. And what I found is that a lot of times the families sometimes just want a little bit more time so they can get extra loved ones there from out of state or out of town. And so it's not quote unquote wrong to intubate somebody, to give them more time, to allow some of the people to come in, see the patient, process the information, which sometimes takes time and space for them to process. Sometimes it takes an hour, sometimes it takes days, sometimes it takes weeks even. But the tool of giving them time and space to process and understand and see the trends over time, I think is very helpful. And so being willing to let them do that, let them be full code, let them have the time limited trial and continue those dialogues over time. And eventually, hopefully, the family will get all on the same page among themselves and hopefully all on the same page of the patient and in agreement with the medical recommendations. But that often takes time. I think you're muted, Gretchen.
So I was talking to John. We had this case yesterday. I'm like, hey, share your case. So I'll just share a little bit about what you just said in a case. So.
We went through multiple.
Can you hear us now? I unmuted by accident. Can you hear us?
I didn't hear that.
Oh.
Can you hear us now?
I can hear you, Gretchen.
Okay, now you talk and I'm unmuted. Okay. You're fine. I'm unmuted.
So, okay, can you hear me okay now?
Yes.
Oh, okay, thank you. So yeah, we had a case yesterday where a patient had a multiple cardiac arrest and now on ECMO. And yeah, so we talked to the family and then they're trying to try. Okay. And family was asking if the ECMO fails, can we turn it back on just to buy some time for the family and friends to come by and say goodbye. And actually, we talked to the critical care team, and I think they're in agreement with us in terms of to get some more time for the patients.
So it sounds like using ECMO to buy more time for the sake of the family. Is that what you were saying? I caught about
yes.
Okay.
So they were going to see if the patient can survive without the ECMO by turning it off and see how he does. And if he is not doing well, then according to the plan, that would be the end of treatment. But family was asking if that's the case, then can we actually put the ECMO back on just to buy more time for the family and friends to come by and say goodbyes?
Sounds like it'd be easier to leave the ECMO on and have the family come now.
Yeah.
To take it off and then restart it.
Yeah, I don't think it was going to be taken off all the way. There's a lot more complications. He has an open chest and they're going to close it. He could die from that. So when we came into the consult, they're like, this is a family that's not agreeing and there's all this conflict. But when we go through the process, have you laid it out here, is understanding who he was, what's important. Everything just became very clear. They just want to have closure, peace, and all these things. So the plan became very clear after we took time to get to know them. And I think they're going to wean down and they could go back up. It's like pressers, you're going to go down and maybe you have to go back up on the pressers just a little bit for that day to get people there. But we did recommend come in now. Things are probably not going to go well. So we are having family come in now, knowing that this probably will not go well. So, but the option, which usually it's like, well, we're never going to go back up, but I don't think they'd turn it totally off and then turn it, redo it. I think it's just things aren't going well. Let's just make sure everyone's here and then do this, with the hospice team and everything.
Yeah.
It just utilized a lot of the things that you shared in the process of having this conversation with family.
Yeah. And I like the way you said it was taking them or weaning them off the artificial device to let their body do it on its own. You know, basically, because sometimes families, maybe they don't really understand that off the life supports, the person's not likely to survive. You know, maybe they really want them extubated because they are hoping to be able to talk to them, but they may not be able to be strong enough on their own. But sometimes even using that terminology helps the family realize, well, yeah, we're all in agreement. We want the person extubated or removed from the ventilator life support to see what they can do on their own. And if they're not strong enough to make it on their own, at that point, I think it's a lot easier for patients' families to embrace comfort care, whereas they may be still hanging on to some hope while they're still on the ventilator. Someone asked in the chat about financial issues or financial burdens. And you're right, we rarely explore this as one of the factors. It can be an area of conflict. One of my mentors years ago said, when something's funny, follow the money. So when people seem to be irrationally wanting someone kept alive no matter what, and again, it's not something we often or usually bring up in our goals of care conversations because it sounds like we're just focused on the money. So that's why we don't usually bring it up, but maybe the social worker could get away with asking about it, or the care manager, in the context of asking about their needs and social supports and any financial stressors that they might be experiencing. Maybe the family is living in the patient's house, and when the patient dies, they become homeless, or maybe they're depending on that Social Security check. So, you know, until the first of the month, we're going to keep them full code. And then after that check comes, okay, we'll agree with DNR. I've seen that happen at least once in the last year or two. But yeah, those things can definitely be factors. And so that's why utilizing your whole team, the interdisciplinary team, to address some of those issues, whereas that way the medical providers won't be the ones addressing it because it seems like it's a conflict of interest, or like they're just concerned about the money, which is not a message we would want to convey. But a social worker could explore that further without it seeming like that's all they're concerned about. Okay. Speak to how the process of inserting a G-tube in an ER setting might play out. I work in South Bend, assuming that all decisions differ at times, but have noted that it is often harder to eliminate an inserted G-tube. And by G-tube, do you mean a PEG tube or an NG tube? As opposed to a ventilator that has been started or placed. Also pointed out the ERDs, which divides treatment options into ordinary and extraordinary, and labels artificial nutrition and hydration as ordinary, which adds another layer. So yeah. So I'm assuming in an ER setting, we're talking about an NG tube rather than a G tube.
Well, actually, I've had it where we've had a few patients that actually had a surgical consult and had a PEG tube placed.
In the emergency? Or,
yes.
Wow.
They went straight to a PEG and they were vented. And so the patient goes up to the ICU with both, and that's where you start.
Wow.
Yeah. So I don't, instead of an NG or OG, so I maybe it's rare, but I mean.
It seems like it would be safer to put in something temporary.
Yeah.
Because then it's easier to remove. I mean, once you have a G-tube, you're going to leave it in for at least 6 or 7 weeks because the tract has to heal. If you pull it right out, it could become a surgical emergency. Whereas an NG, yeah, they might need to be restrained or sedated to keep them from pulling it out, but it would give them time to see if they're going to either A, tolerate the enteral feeding, B, if they're even going to tolerate leaving it in, In other words, it's a tool. Any of these artificial things, whether it's a ventilator, a PEG tube, or NG tube, G tube, those are just tools. They're tools to stabilize the patient or buy more time or give them extra support because they can't safely swallow or whatever. And they're, in and of themselves, really, they're morally neutral, but they do allow more time, and they allow a trial of tube feeds, for example, to see if the patient is going to be able to handle them. And if not, then don't put in a PEG tube. If they're not tolerating tube feeds well, it's giving them diarrhea, they're bloating, they're having a ton of secretions, they're aspirating anyway from tube feed coming up the esophagus and into the lungs. Well, then the family knows, okay, we've tried that and it's not improving quality of life. It's actually making it worse. And then they've spared them having that surgical procedure. So I'm not a proponent of putting in anything permanent in the emergency department setting, especially if it's something that either could be reversible or might not be tolerated well by the patient.
I'm wondering if that's because of a boarding issue and if the patient was actually admitted to the ICU and utilizing the ER as their holding place. Which is why that might have happened. And sometimes is a case that people are there for days because the ICU is just too full. It would be very, I mean, I can't imagine a context where in the immediate ER course, you would reach for a PEG tube. I can imagine at least our surgeons laughing at that notion.
Yeah. Well, I appreciate you work in the ER. So that's good that you're saying that, but I've actually seen at least 2 cases since I'm doing hospice. And, we get through it. It just, once it's permanent, it's almost like you really have to kind of delve into that topic of not starving the patient and that, it's in, but we can still say, let go, you with me? It's not like this permanent thing that says, okay, well, it can be tough, I guess.
Did they reach right for trach too?
I'm sorry?
Did they go right for trach too? Just intubation, go right.
Oh, no, they went in, they intubated and put them on a vent. No, no, which is interesting. Yeah, that's it. Thank you.
All right, thank you, everyone. I believe we have a case coming up. So I'm going to jump off and turn it over to the fellow.